the thought of doing a vaginoplasty in an office setting is kind of crazy.
So 2005 is when I first doing that in the office. And yeah, well, I was nervous on my first few dozen or so. But after that, I realized, man, this is safer than doing it in the operating room. The patient's awake, talking to me. They go home. They have no tube down their throat. They have no needle in their spine. And I thought, this is a better way. I need to start teaching that. And so that's when I started teaching. After 2005 is I started teaching my techniques in Laguna Beach. And then a few years later, you came by. I was very happy to see you there.
Welcome to Healthy Her, the podcast designed to inspire women to lead lives filled with health and happiness. I'm Dr. Amy Brenner, your host discussing nutrition, hormones, aesthetics, sexual health, and more. Join us each week as we dive into feeling better, looking better, and living better. Hey everyone, welcome back to the podcast, Healthy Her. Today I have a really special guest. If you're in the know, we actually have like an almost celebrity here with us, Dr. Alinsod. I would say he's probably the father of cosmetic gynecology and invented or came up with a lot of these techniques that we use. I trained with him at the Alinsod Institute and use his techniques. He's also inventor of a lot of devices, the Lone Star retractor that a lot of urogynecologists use in pelvic floor. Welcome, Dr. Alinsod.
Well, thank you for the very kind invitation and introduction. I really appreciate it. It just means that I'm really old and been doing this for a long time.
So I just give people the highlights about your background, but can you give people the extended version of your career path and
sure,
applications and how you ended up being so, just world renowned in cosmetic gynecology?
Well, thanks. It's a tortuous path. I was actually wanting to be a GYN oncologist, and after my residency at Loma Linda, this was I started in '86 and finished in '90. I was actually going to be a gen onc, and I got accepted to Yale's fellowship for gynecologic oncology. And at that time in my career path, that was right after I had also become the first Rutledge fellow at MD Anderson. So my whole career was pelvic surgery because I love pelvic surgery. And so I did all those things, and then I got into the fellowship, and I didn't even get to start. It was a heartbreak because this was the time of the first Gulf War. If you're old enough to remember that, we went to war in Iraq, and I got pulled. I was an Air Force scholar, and so I got pulled out of the fellowship. I wasn't even allowed to start, and so I was exceptionally disappointed. So I had several years of heartbreak because I couldn't do the fellowship. But I was very proud to go active duty with the Air Force, and so I spent a year at George Air Force Base and then 3 years at Nellis Air Force Base in Las Vegas, and that's where my background of gyn onc helped me because I was able to transform a lot of those vulvectomy surgeries I had done during all these rotations, and the vaginoplasties that I had done. I had 2 urogyns in my residency that proctored me, preceptored me, and almost like a fellowship for 3 years at Loma Linda. And so I transformed a lot of those exoneration vulvectomy, radical vulvectomy, modified radical vulvectomies into cosmetic GYN type procedures. I didn't know there was a demand. I just thought the way we were doing it wasn't really pretty. We were trying to save lives with gyn onc surgeries. And so I just modified some of those procedures and started doing things like labiomajoriplasty, which wasn't even a term there. It was modified radical vulvectomy. And I started doing labioplasties for the Air Force wives. I was the doctor for the Thunderbirds. If you guys remember those aerial acrobatic teams in Las Vegas, I was at Nellis Air Force Base. And so the people there knew of my love for pelvic surgery. So they asked if I could do their labial surgeries to change the appearance and all that, minora majora, hood area. So I started doing it because I was Air Force. It was all done for free. And then when I got out of the Air Force in 1994, I loved pelvic surgery. And at that time, 1994 was when, in Europe, Gynemesh was being developed and transobturator slings and things like that were being researched. And so I dove headfirst into that, and I ended up teaching GYN at Harbor UCLA for their fellowship and at UCLA for their residency. And so I was in early. There were no fellowships for urogynecology at that time. So I became since I had a lot of experience in pelvic surgery, they made me a clinical professor. And that's how I started. I started teaching the residents and Harbor UCLA fellows. And I got in urogynecology. Yeah, but I had all that background in cancer surgery, vulvectomies, and things like that. And so I started doing that together. None of the fellows really were interested in cosmetic GYN or making things pretty down there. They just wanted to learn how to do mesh repairs. I was the guy who taught how to do augmented repairs with biologics and with ultra lightweight polypropylene. I brought the ultra lightweight one from Scotland to the United States in 2005, and it's still the surviving polypropylene mesh out there. It's called Restorel now, but when I brought it in,
patients that are listening, yeah, talking about the mesh that people use, that physicians use for prolapse, so
right,
and rescue seals and things like that.
Yeah, it was remarkable because these ultra lightweight meshes in the right hands in a trained surgeons were so wonderful. The failure rates were, 1 or 2% instead of 16 to 20%. But because so many untrained people were doing these type of procedures, the FDA finally clamped down, and most of the mesh products left the market, as you know, about a decade ago. But the surviving one, the one that Coloplast still has, it's called Restorel. That's the one I brought into the market back in 2005. And that's been, I still use it occasionally on the worst severe cases. I still use it once in a while, not so often anymore because of all the backlash and all the legal action that goes on with that. But that's my background. I changed a cancer surgery into a cosmetic one, and I also love pelvic reconstruction. And so I used all the urogyne skills that I had learned from my esteemed staff, and I just modified it. I changed it so that it could be done in the office. Because remember back then we did everything in the operating room. Sure. No one did these type of procedures in the office. So when I got out of my first 10 years of private practice, I left the Air Force and then I joined a group. I worked 10 years, did mostly gynecologic surgery. I left there and moved my practice to Laguna Beach in 2004. And in 2005, I started seeing patients and all those things that I had learned, but I couldn't do much of because I was in a group that was heavy in insurance. I stopped taking insurance and I started doing, excuse me, a cash business.
Started your own practice in Laguna Beach? Okay.
Yep.
And the cosmetic gynecology started?
For me, it was when I went 100% full-time into cosmetic gynecology, 2005. And that's when I was finally able to put all those skills I had learned into the office. Office labiaplasty, office vaginoplasty, perineoplasty, all those things that I had kind of mastered in the operating room, I brought into the office. Because in the last few years of my private practice, I would tell the anesthesiologist to just get the patient lightly asleep, and then I would give local anesthetic, and that's all they would do. They would just get the patient comfortable enough for me to do my local anesthetic, and that's where I learned all my local anesthetic skills. My excuse me, my pudendal block, which we all learn, right? You learn pudendal blocks in residency for obstetrics, but not for pelvic surgery. And so we know we both know pudendal blocks don't work for deep pelvic surgery. So I modified it and added the levator block to it, and I injected not just the pudendal nerve, but the levator branch of the pudendal nerve into the perineum. And I was shocked. I was able to get these patients comfortable so that I can do these deep dissection, these deep surgeries when they're talking to me. So 2005 is when I first doing that in the office. And yeah, well, I was nervous on my first few dozen or so, but after that, I realized, man, this is safer than doing it in the operating room. The patient's awake, talking to me. They go home. They have no tube down their throat. They have no needle in their spine. And I thought, this is a better way. I need to start teaching that. And so that's when I started teaching. After 2005, is I started teaching my techniques in Laguna Beach. And then a few years later, you came by. I was very happy to see you there.
Yes. So one of the things I learned from you, which we're going to talk about today, is vaginoplasty. And you perfected this technique and have taught a lot of doctors worldwide. I trained with you, I don't know, several years ago, and you're right. The thought of doing a vaginoplasty in an office setting is kind of crazy, but you're right. It works really well, and patients are comfortable and just sleeping or playing on their phone or listening
Yeah,
to
most
their
of the time they're texting their friends, and sometimes they turn their phone around and say, "Hey, Dr. Alinsod, say hello to my best friend."
yeah. So let's get into it. Some people might not even know what a vaginoplasty even is. So can you just start at the beginning and what is a vaginoplasty? What are we even talking about?
Sure. Well, vaginoplasty surgery is a surgery where you reduce the diameter of the vagina from a gaping opening, and also not just the opening, the deep part of it, to reduce the diameter. On average, reduce it half the size of what it was. That's probably the average, is half reduction. And this is a procedure done for patients who have reduced friction. They don't feel their partner. Sometimes they're anorgasmic or have a very difficult time achieving orgasm because they just don't feel their partner. And one of the terms I'm sure you've heard it is, what is it? A hot dog in the hallway. You've heard that, and that's a lot of my patients say, I just don't feel my partner. And it stems mostly from the stretching of tissues during childbirth. Childbirth is the number one cause of looseness or laxity or increased diameter. So we call it vaginal laxity or loose vagina. And these are the patients who come in and who want to have increased friction and to narrow the size of the entire canal, not just the opening, not just the way it looks, but reduce the gaping look, sure, but also reduce this diameter all the way up. Patients who do a lot of weightlifting, chronically bearing down, patients who have connective tissue disorders like Marfan syndrome or Ehlers-Danlos may have stretchy skin. And even if they haven't had babies, because of the long-term bearing down, like for example, chronic constipation, that can stretch skins. I've done vaginoplasties on patients who've never had babies, but were super heavyweight lifters, Ehlers-Danlos, Marfan syndrome. They're the ones that also have laxity, but I would say 98% it's patients who've had large babies or even normal sized babies that can stretch everything out, because it depends on the size of the partner too. The diameter of the partner is important.
How do you assess, and I know this is what you taught during your course, but how do you assess, or could you explain to people how we assess if somebody's a good candidate for a vaginoplasty? Certainly they come in and during the consultation say all those words that you mentioned is, I typically hear things like, I just feel dead down there since I had kids and I just don't feel anything. I feel like I'm gaping. I just feel so loose. But when you're doing an exam, what are you typically looking for?
Well, typically after, I don't even ask the patients about vaginal laxity or looseness. I have it in my intake form. I have checkoff sheet where they'll say, I can't feel my partner. I feel loose. I have vaginal gas. I'm passing vaginal gas when I squat, exercise, or have sex, or even my partner says he doesn't feel anything. I'm having a hard time having an orgasm. So I have all those down on my intake form. So I typically I don't even have to ask. I look at the page and I see the check sheets, the checks on one side of the page, and I know this is the problem they have. They're concerned about the looseness, and then the other side of the page they've checked it off, and those are the checks for like large labia, irregular labia. They're too long, so I have it segmented. It's pretty easy. So I can take look at my piece of paper and know what their symptoms are going to be. So my intake form asks them, and then I ask them personally. So is this a concern for you? Because a lot of people with a gaping vagina or loose vagina, they have no issues, and so I don't try to bring it into their head that they have issues. If they don't complain of it, I don't bring it up. If they check, then I will ask them, is this an issue? Does this bother you? Is this embarrassing? And then I'm really attuned to the patient who wants a second chance in life. For example, the one that's just recently divorced. Okay. And that's a lot in my population. When I was in Laguna Beach, the average age of my patient was about 44, 45. It's a beach community, wealthy community. And so there was people who wanted second chances in life. They thought that, okay, I'm divorced, I can start dating now, but I don't have that confidence. It just looks ugly down there. It looks so gaping. And I don't, when I've tried having sex, I don't feel my partner. My partner complains. That's not so often, but sometimes I get that symptom told to me. And those are the ones I will tell them, well, you have choices nowadays. Before, you kind of just have to live with it, but nowadays you can actually have a choice to try to increase your sensitivity, reduce your friction, increase your quality of life, reduce the diameter of your vagina, and we can do it either non-surgically with the new lasers or radiofrequency device, or we can do it more aggressively with surgery, a vaginoplasty. If they have, for example, a lot of people, you've seen this, a lot of people come to you and they feel loose, but when you examine them, they have this bulge coming out. They have a prolapse of a rectum, typically, or a prolapse of a bladder coming out. And those are the people you can combine both a functional repair, a posterior repair, get rid of the bulge, and then on top of it, do the layered closure to give them the exact diameter. And that's kind of my bread and butter, because I'm a urogynecologist. I fix a lot of pelvic prolapse. And then these patients, while I'm there, they're going to want to have an improvement in the way it looks, the entry, and also full depth. And that's really the core of my practice, is combining the function with the appearance.
I've had several patients who have gone to a traditional urogynecologist or a traditional gynecologist and had the bulge fixed, had the rectocele repair or the cystocele repair, and they're thinking that this is going to fix the laxity feeling or the decreased sensation. And I've seen a lot of people where the bulge is gone, but they still have laxity. And when I examine them, I could still put, four or five fingers in, and it fixed their bulge and their feeling of pressure sensation, and fixed the medical problem, but didn't really fix the sexual sensation problem.
Yeah, that's a problem for the patients, because they're coming in for two things: the functional problem, like, for example, they'll tell you that they got this bulge and they also can't get the stools out, right? They're getting stuck in the perineocele, right behind the perineum, but then they're also loose. But we're all trained to fix the posterior repair, but few are trained in how to reduce the diameter. Or the doctor who's not trained in doing vaginoplasty will say, oh, it's the same thing. You just trim the excess vaginal tissue off and you'll get the tightness that she needs. But that's not true. You and I know that's not true. You've got to do the layered closure, but no one teaches you that, because in residency, they were so afraid to do the tightening surgeries because they thought it would cause long-term chronic pain. For example, I got trained as a urogynecologist in using placement of the levator muscles into the midline, levatorplasty, basically. And that was a tremendous benefit for me, because not just for the reduction in the rectocele, the worst kind, or even the perineocele, I was able to get failure rates less than 1%. And when you do the traditional repair, when you do plication or site-specific repair, your failure rates are 10 to 20%. Plus, the levatorplasty actually reduced the diameter of the vagina. So my personal way of doing a vaginoplasty is I'll take care of the rectocele first, and then I will do a levatorplasty also to reduce the entire diameter of the vagina. And that's where I got a lot of crap from doctors telling me that I was going to cause long-term pain. They kept telling me,
and
yeah,
have we?
no, 37 years of me doing this, my long-term dyspareunia rate is less than the reported complication rate doing a standard posterior repair. My failure rates are lower, and my patient satisfaction is higher. There are times where I do it too tight, where the patient switches partner to a larger partner, a larger diameter size partner, and I'll have to release or loosen the vaginal canal a little bit. It's a minor procedure, so that's a risk that I tell the patient, but it's very, very low. I would say in my hands, it's probably 2 or 3%. It's not zero. I have to do some band releases every year because I do so many of these, but not very often.
Yeah. What is the difference between a vaginoplasty and a perineoplasty? And at least my experience, when I've looked at other people's websites, or I've seen other physicians like put their surgery on YouTube, and they're saying they're doing a vaginoplasty, but it's really just a perineoplasty. So could you explain to people what the difference is, and how would you know if you're, looking at different doctors' websites of, are they really doing a vaginoplasty or are they really just doing a perineoplasty?
Well, first, you have to find out if the surgeon is a gynecologist or a plastic surgeon or a cosmetic surgeon. That's the first thing. For example, if you read the website for plastic or cosmetic surgeons, they use the term either vaginal rejuvenation or vaginoplasty. Just read it. I read it just recently, and then they describe what a vaginoplasty is. But when you read it, if you're a gynecologist and you read it, what they're actually doing is a perineoplasty. They're removing a V-shaped, or I'm sorry, a pyramidal shaped area right to the level of the hymen, and then a V-shaped area into the perineum. That's a perineoplasty. You and I do those like repairing an episiotomy, right? That's what they're doing, and they're calling it a vaginoplasty. So it depends on what specialty is telling you what they're doing. Really, go to the plastic surgery website or go to the cosmetic surgery website and look at their description. They are not going deep into the vaginal canal. They are not putting levator muscles together. They're not going down to the ischial spines. Now, for me as a gynecologist, you're a gynecologist, my definition of a vaginoplasty is going deeper than the perineum. My work is actually past the perineum. The perineum, for those, if the lay public will see this video, the perineum is what you see. It's that space between the opening of the vagina and the opening of the rectum. When only that is fixed to make it look like it's narrower or smaller, that's a perineoplasty. That is not a vaginoplasty. Okay, no matter how you describe it, that's a perineoplasty. A vaginoplasty, to reduce the diameter and to increase friction during sex, is when you go deeper inside, almost to the top of the vagina, at least to the level of these bones on the side of the pelvis called ischial spine. There's one on each side. You palpate it and you feel it. You dissect all the way down there. And then once you expose the levator muscles, those are the muscles on the side, you then bring those muscles to the midline and create a new hammock and push the rectum down so it's not bulging out. And at the same time, you fix the opening, make the opening pretty and tight, but you also bring those muscles together deep inside the levators, and you create a narrower vaginal canal. And that in my definition is the true vaginoplasty. It's not just fixing the opening. You can't just fix the door. You got to fix the entire hallway.
Now, what would you say to people that would say, well, I'll just do Kegels or get physical therapy, or there's some devices, some vaginal weights you can put in the vagina. Why can't somebody just do this?
Well, those are great tools. Really, they are. They're great tools for something called stress urinary incontinence. And in some cases, they may help the overactive bladder. So, for example, Kegels will strengthen the muscles, right? So that you can hold your urine or stop your urinary flow in the middle, or reduce the accidents when you cough, sneeze, and jump. But Kegels don't do anything for narrowing the vagina. They just strengthen the muscles. They don't do any of this. They just strengthen this. So they don't do any of this. Those balls, the Benoit balls and those vaginal weights also force you to clench and strengthen those muscles. So they may work for incontinence, but they do no help in reducing the diameter of the vagina, and they won't increase friction. If the patient gets strong enough that they can clench their muscles, they may be able to grasp their partner better, but it doesn't reduce the diameter of the vagina. And when you clench, it's just for a short period of time. You can't clench the whole time you're having sex. You're exhausted, and you're thinking about clenching the whole time, and it's not pleasurable because it feels, man, it's too much work. My patients tell me it's too much work. It's too much work to get an orgasm. And so that's not the ideal way to do it, but it helps in incontinence.
You and I both perform these procedures in the office. If a physician is listening to this and they were like, that's crazy, like, why would you do something like this in the office? Let's dive in a little bit more about the safety of these types of procedures in the office versus an operating room. And, way back when I first started doing this, I was concerned like, oh, are patients going to want to have this in the operating room? And so at the time, I actually did contact my local hospitals of, well, what would be the price if I gave people an option of doing this in the hospital? And even before COVID, it was just ridiculous of what a self-pay cost would be, because these are procedures that are not covered by insurance, of a vaginal tightening for sensation and things like that. But then post COVID, it was just ridiculous. So now I don't even give people an option of having these procedures performed in a hospital setting. But let's just talk about the safety of doing this in the office.
Well, let's talk about, you hit on it, the price first. If you do it in the hospital or the surgery center, your cost is $14 to $16, or $1,400 to $1,600 extra per hour for the patients, and these will take you a couple hours. And so easily the patient has an extra fee of about $3,000. Okay, and that's just an average case, such as a vaginoplasty or a labiaplasty. So bringing it into the office, one, the gynecologist who brings this or the plastic surgeon who brings this into the office will be price competitive, because now they've saved their patients all this money, and the patient may choose you because they look at the bottom line, and your procedure in the office is about $3,000 cheaper, basically, if you look at the pure numbers.
I don't know where you got your prices for. Mine were like in the 10,000 range.
Yeah, well, I negotiated my surgery center to limit my cost to about $1,500 to $1,600 per hour. So that was with a lot of negotiation. And most people, I had a lot of cases that I brought in, so they were able to negotiate that fee for me. But if you don't do a lot of them, you're right, it will be $5,000, $10,000 extra. Mine was a negotiated fee for my patient. So there's the price advantage right there. So for the doctor, the patient sees, yeah, okay, so this doctor costs less and I'm going to get the same results. And so I'll choose to do it in her office. I'll choose her to do the procedure. And then they hear that there's no tube in your throat. There's no needle in your spine. And, you've seen the way I do it. I don't even have an IV. There's no IV. The patient's sipping water the whole case. She has a straw. She has the water right beside her, and she's sipping. She's talking to me. And the patient has had a great breakfast. It's not an NPO. The patient's awake and talking. So we make sure that they've had a good breakfast, and they're very well hydrated. So the safety is there because we know how to numb it. And it's taken a decade to figure out the protocol. But do you mind if I share the protocol so the doctor who may be watching may understand how safe it is?
Sure.
So the patient comes into the office, and we give them Ativan and maybe a little narcotic. Sometimes they don't want the narcotic, but usually we give them like a couple milligrams of Ativan and anywhere from 2 to 4 milligrams of Dilaudid. If I have Demerol, I'll use Demerol. And they come in also after having placed numbing cream, a 30% BLT cream, bupivacaine, lidocaine, tetracaine. They place it on their vulva or wherever we're doing surgery. If I'm going to do anal skin tags at the same time, we'll put that numbing cream around the anal canal. And if I'm doing a vaginoplasty, like we're discussing, I put some of that numbing cream deep inside the vagina. I'll tell them, just put in your finger and put it in as far in as you can. That should be enough to numb the opening at least. So by the time they get into my office, they've had an hour of numbing. And then all the consents are signed already the prior day. I've answered all their questions. And then I give them those pills. And then what I do is I use a device called predictive permeation. It's a wonderful device. I probably couldn't be as successful in my office vaginoplasty if I didn't have this device, even labiaplasty. It's a device that changes the polarity of your skin. You put the numbing cream on the vulva or the vagina, and there's this one device, and you use it all the way around. And what this device does, it uses milliampere energy, anywhere from 1 to 3 to 5 milliamperes, really low level energy. But the polarity changes, I can't remember exactly, but let's say 1,000 times a second. So the polarity changes so rapidly that the water channels of the skin are frozen, and macromolecules, big molecules, and small molecules all go down this water channel. And for us, it's numbing cream, goes down the water channels and gets them number. And so now they have the initial numbing when they come in, and now we make it even number. So now I'm able to do my injections and they barely feel it. I use my injections with bicarb. And so with the bicarb, it's made a world of difference. They barely feel the injection. They may feel a little achy at the initial injection around the ischial spines or the levator muscles. But after injecting, let's say 10 cc's per side and 10 cc's at the opening, the patient is pretty numb and ready for your dissection. You can dissect like a standard posterior repair, and you can dissect all the way down to the ischial spine very comfortably. And if the patient's uncomfortable, feeling pain, you've got extra and you just inject it. I use a 30 gauge needle and I go exactly to the place that they're tender. I'll palpate it and I'll say, is this where you're tender? And they'll say, yeah, I can feel that a little bit. And then I'll check it. And if they're still tender, I give maybe a cc in this area, 2 cc's. So I'm doing this entire cases with about 40 cc's of Marcaine with epi. And then at the very end of the case, let's say I've done all my dissection, I've done all my posterior repair, levator, bringing it to the middle, trimming off vaginal mucosa all the way to the top of the vagina, and then suturing those in layers. I'll close the levator muscles in a couple layers, and then I'll close the vaginal mucosa in 1 to 2 layers. And so that's typically 4 layers of closure. So I've never seen one break down in 37 years because there's so many layers down there. And then at the very end, I will use Exparel. For those of you who don't know what that is, it's long-acting bupivacaine. It's bupivacaine coated in a liposome coat. And so I inject it at the very end, and the patients will then have anywhere from 1 to 3 days average of good pain management, pain control. I've had a patient last as long as 5 days. I then put a Foley catheter in for about 4 days because sometimes it's hard to pee when you have so much pressure down there. The patient will feel more pressure than actual pain. And so I put that Foley in. They walk home. They go home right after the vaginoplasty, posterior repair, and even with the labiaplasty if they want to do that all together. So I'm able to do all those things. The labial surgery, the posterior repair, the vaginoplasty, perineoplasty, and now I'm doing more anal skin tags than ever. We've become the anal skin tag capital of the Midwest and South. At Dallas, we have so many cases. We're found. We really market for anal skin tags, and all the colorectal surgeons, general surgeons really don't want to do it. So now it's part of our package. It's fantastic.
Yeah. Why is it that so many colorectal surgeons don't want to do these procedures? And that's usually the first question I ask patients that are coming and asking about anal skin tags is, have you ever seen anybody else for this? And I would say the majority of patients have reported, yeah, I went to a colorectal doctor and I was told this isn't a medical problem, so we don't do anything about it. Has that been your experience?
Yeah, that's the problem. The general surgeon and the colorectal surgeon, even the GI. And I had one lady that actually saw a dermatologist who removed the small anal tag for her, but they don't want to do it. They just say, it's not covered by your insurance. And that's the number one reason. It's not covered by insurance. And if it's covered by insurance, some insurance will pay for it. It's not worth the doctor's time. They'll get less than $100 for spending all that time. You know how much effort it is and how tender and painful it is if you don't know what you're doing. There's a special way of numbing these areas, and I discussed what it is, how I do it. But if you don't do it that way, it's one of the worst procedures to do in the office. This is even more painful than a vaginoplasty or a labiaplasty. So that's why colorectals don't want to do it, because one, it's painful. They get paid very little. And so why do it? And so we capture the market. We aggressively market for this because we know how to numb it. We know how to take care of it. And with the radio frequency or laser devices that are out there now, the procedure is exceptionally safe and the results are just beautiful.
Yeah. I think it's really only been covered by insurance is if it's combined with hemorrhoids, and then they usually take care of the hemorrhoids, but do a aren't doing a great aesthetic result for the anal skin tags. So
And that's what I see. I get a lot of redos. I've had patients who've had both internal and external hemorrhoids taken care of, but the doctor did not want to do the anal skin tags. You know how big they are sometimes because it's wrapping all the way around the anus. No colorectal surgeon wants to do that because one, it's only cosmetic and they don't get paid much for it. And the recovery is so tough for these patients if they don't have the proper pain management. Who wants to deal with that? It's a big headache. But for us, we look at it as an opportunity. And I my grads all learn how to do anal skin tags.
yeah, what should we tell our patients of what to expect post vaginoplasty? So
Well, after vaginoplasty, the pressure feels like pulling on tailbone because you're putting all these muscles back together into the midline. So I tell my patients the worst you're going to feel is rectal pressure. It's going to feel like someone's pulling on your tailbone and you're going to waddle because it's going to be uncomfortable for your first week for sure. And you're going to have to take ibuprofen and a mild narcotic. And I typically tell them you need to take it together. Okay. That's how to manage pain. And if they've had an anal skin tag removed along with that, I give them a lot of numbing cream so that they can use that in the anal area so that when they have bowel movements, it's comfortable. But more important, my number one complication really after a vaginoplasty, it's not bleeding. The bleeding is very little, very, very little. It's not infection. If you're going to get an infection, it's a bladder infection, not the rectum infection or anal tag infection. It's a bladder infection. And then all these patients go home on antibiotics. But the biggest complication is constipation. I have a whole sheet, post-op instruction sheet. And number one thing it says there is you've got to be on your milk of magnesia. That's my secret weapon. Milk of magnesia, prunes, prune juice, fiber, even colace, occasional Dulcolac suppositories, whatever it takes to keep your stools the consistency of toothpaste. And we tell this to the patient on their pre-op. When they're talking to us, when I'm doing surgery, we review the post-op care. They go home with this sheet. And then we call them the next day and we ask them, how are you doing? Have you had a bowel movement? Is it the consistency of toothpaste? That's the goal. So if they're able to keep it the consistency of toothpaste, they do just fine. So the first week's a little tough because there's a lot of rectal pressure, but we encourage them to walk around. There's no babying. There's no sitting around the house just watching TV. We tell them walk around as much as you can tolerate. You're going to get fatigued fast because, your body produces these things called prostaglandins that make you feel tired. But when you take your Motrin, it's like an energy pill almost. And please walk around as much as you can. Move your legs. We don't want blood clots. In all the years I've been doing vaginoplasties, about 36 years, I've had one pulmonary embolus, and that was from a patient I did in the hospital. She had Levinox and all that stuff. And she was a doctor's kid, doctor's daughter. She ended up with bilateral pulmonary embolus 6 weeks later. And that's my one pulmonary embolus. But whether you did that at home or in the office, it wouldn't have made a difference. She had it 6 weeks later, and then I had to admit her, and we had to dissolve those clots. But it's an exceptionally safe procedure in the office because the patient's awake. They're talking to you. I've had, let me just talk about some of the complications I've had. UTI, probably less than 1%. Too tight. I did it too tight, or she changed to a partner that's larger. That's anywhere from 1 to 2%, somewhere there. And I'd have to loosen it. Most of the time, if it's too tight, they can use vaginal softening exercises, which is the use of your fingers or dilators with vaginal estrogens over a couple of weeks to stretch the tissues. And that's usually all you need. But you will get the occasional one where that isn't enough and you're going to have to loosen it, actually make an incision right in the middle and create a band release. And so it's been very, very successful. Now, will the patient who've had a vaginoplasty be orgasmic? No, I can't guarantee that. That's a separate issue. My surgery, I tell the patients, you'll get increased friction. We'll get rid of the bulge. It'll look better. You'll feel more tightness in the opening. But orgasms, I don't know if you will have any or will be improved. That's one thing I don't promise. And I tell the patients usually for orgasms, you may need other modalities to help you. For example, platelet-rich plasma, injection of PRP, the O shot in the genital area. And so that one I don't promise.
Yes, I couldn't agree more. Is I tell patients, this is a procedure to tighten the vagina, period. But there's so many other factors that go into good sex. So the things you mentioned, hormone optimizations, there's certain medications like SSRIs that can interfere with orgasm. So, it's multifactorial. And this is just one of the many things that can go into, good sex. So,
Well, after you do the surgery, I tell the patient, okay, we've had a good start. I think we're going to transform your life once you're healed. And I tell them healing is between 6 and 8 weeks. I tell them as soon as 4 weeks, sometimes all your sutures either fall out or we have removed them. Typically, if they live in the area, they come in and I trim the sutures off at week number 2 because those sutures get itchy and they get very itchy. And if they get very itchy and they live far away from me, I'll tell them to use Benadryl cream, and that works really well. But if they live close to me and they're willing to drive in, they come in at 2 weeks and I trim them. More than half of my patients are from out of state. And so I just tell them to use Benadryl cream and the sutures absorb on their own. So for maintenance, I tell the patients after surgery, you've got to be on vaginal estrogens. The estrogens will increase the blood flow. It'll increase the production of collagen. So your skin is improved and thick and not thin and glassy. It'll also increase the elastin so that your skin is stretchy. So on all my patients, I put them all on vaginal estrogens basically every night for 6 weeks. And after that, if they're perimenopausal or menopausal, I'll tell them to maintain it with vaginal estrogens 2 to 3 times per week. My favorite is estrogen cream, such as Premarin or Estrace in the first 6 weeks. But to maintain them for ease of use and convenience, I usually switch over to Invexi. That's my personal favorite. I like Invexi because it's easy. It's a little pill that you put in twice a week, 2 to 3 times a week, and it's easy to maintain. And then I tell the patient also that if, for example, if the patient had an O shot or something to help their sensitivity, you should have those touch-ups every 6 to 12 months. The O shot, the injection of PRP into the clitoris or the G-spot area, have that done at least once a year. And then if you're menopausal, you want to keep your tissues the best possible, and you want to improve your sensitivity, I may be biased because I recommend radiofrequency on these areas. For me specifically, I like Thermiva because it has the right wavelength, 460 wavelength, to increase the density of the small nerve fibers on the clitoris and the G-spot area. And many of my patients with this treatment have a reduced time to orgasms. I did a 2016 study published, and it showed that when you use radiofrequency, without even the O shot, without the PRP, just radiofrequency alone, you can reduce the time to orgasm by 1/3 to 1/2. And I found that to be continuous, even after a vaginoplasty, even if you're in menopause and onwards, if you keep the radiofrequency treatments maintained at least once a year. I have patients who come in every 6 months, but at least once a year, it seems that the time to orgasm is reduced and it's easier to achieve it. It doesn't work for everyone, but that's my personal recommendation.
Radio frequency post vaginoplasty as a maintenance.
Yes, I do. I use radio frequency as my maintenance. And I tell them you've got to, and the way I approach it is you just spent a lot of money on this procedure. You have to maintain your investment, keep your investment as pristine as it was from the first month after surgery. And so that's how I tell the patient, and they understand it. You've got to maintain your investment. It's just like when you get tightening of the face with lasers or with RF. If you just do it one and done, it's worthless. You've got to maintain it.
Yeah. You mentioned earlier, and I do the same, is a lot of patients combine cosmetic gynecology procedures. So somebody may choose to have a labiaplasty minora with a vaginoplasty or a majoroplasty with a vaginoplasty. And we'll let you go. We won't talk to you all day today about all those other procedures, but I want to just talk a little bit about maybe the controversy in general about cosmetic gynecology and ACOG's opinion on this. I think they've definitely, the pendulum is definitely swinging. And it's not as, I don't know, taboo, or maybe if you could just comment on that. I know you were recently asked to speak at a grand rounds about cosmetic gynecology. So that just tells me that things are definitely moving the other way.
Well, when I first started doing this, definitely there was a bias against gynecologists doing labiaplasty surgery or anything cosmetic in the genital area. The toughest ones were our own organizations. The American College of OBGYN was very much anti cosmetic gynecology. They had two committee opinions published. One was 2007, I believe, and basically it says it's a not a necessary procedure. It's untried. There's not enough long term data. It's unsafe, etc. And that you should consider other things, like if you, for example, if you're one who wanted labiaplasty, they even wrote things like, well, wear a panty liner or a pad to hide it. I mean, really silly stuff. Tuck it in, basically, and do all these things, or just live with it. Let's say you have labia that are touching your inner thighs already. They basically live with it. It's like telling someone who has asymmetric breasts or a crooked nose, oh, just live with it because it's part of normal. These patients want an improvement in their appearance. That's no difference in the GYN world. But we had that problem for a decade. You faced it, I faced it. A lot of GYNs would say, what are you doing that? That's normal stuff. I've had so many nasty letters and emails sent to me, and I read it and I go, well, all right. I mean, we're offering something for women. Feminists want us to give options, and here we're giving options, and there we're getting slammed for giving the patient options that they choose, right? And so 10 years later, the American College of OBGYN write another opinion paper. Basically, they limit it to teenagers, basically saying, well, if they have an issue with it, they should consider all other options, like we said 10 years ago. But, as long as you know the risk, benefits, and options, it's okay to get a labiaplasty. But if you read that article, it specifically focused on teenagers. They didn't say anything about the mature women. So, now fast forward 5 years later, I think the minds of the American College of OBGYN and organizations such as AAGL and OGS have completely been opened, because now American Urogynecologic Society has a working group, and they're writing committee opinions on this, and they're actually looking at it. We may not agree with everything, but at least they're looking at it. And American College of OBGYN has sponsored me now twice. District 9 and District 4, they allowed me, they invited me, they paid for all my expenses and wanted me to discuss cosmetic gynecology. So this summer, I just did District 4 for the West Indies, Argentina, the East Coast, and I just did that one. And District 9, 2 years ago, I did for the Armed Forces District. And then I got invited to grand rounds at Loma Linda University to talk about this to their residents. I was able to do a grand rounds also at a Dallas Presbyterian Hospital and other places. I've done quite a few talks to the general lay OBGYN who are wanting to learn about this. They may not go into it, but they want to know what it is. And so I think our college is slowly becoming accepting of this, because I'm not the only one they've sponsored to talk about this in their district meetings. I really believe soon, if they don't do it, they realize if they don't do this and teach their own fellows and residents, this is going to go to the plastic surgeons or go to the cosmetic surgery field. And I don't think our specialty wants to lose this.
Plastic surgeons have been doing it for forever. So
yes,
which leads me to my next topic. Let's end on this. I know I trained with you, and training with you at the Alinsod Institute versus doctors who may think like, okay, well, I'm a gynecologist. This is my area. I know how to do this. What is the difference? Obviously I know the difference, but since you are a teacher of this advanced cosmetic technique, can you explain to people why, if you're going to start doing labiaplasties, that what you learn in OBGYN residency, in my opinion, really isn't enough if you're trying to achieve a cosmetic result. Certainly, if somebody has a medical problem, I think one time I had somebody who had this big 10-centimeter cyst hanging off of her labia, and that I felt like was a medical problem. I I I remove the cyst, build it to insurance. But from a when women who are seeking a labiaplasty or cosmetic gynecology for aesthetic reasons that are not covered by insurance, why it should be done by somebody who has extensive training with somebody like yourself and at your institute.
Well, you hit on the head. Is that one, we're not trained. It's not part of the program of any residency or fellowship in OBGYN. I believe cosmetic surgery, I'm friends with the former president of the American College of Cosmetic Surgery. They're trying to increase the teaching in this department. So they're dedicating time for their fellows to do it. They're using some are using my Gynflix. I have a platform online with all my decades worth of surgeries, and it's called Gynflix, Gynflix. It's a cheap plug here, but that's where they're learning at least the basics so that they know how to do the steps. Because unless you know the steps, you didn't learn it in residency or fellowship. You didn't learn it in your Gyn fellowship. You didn't learn it in Gyn Onc fellowship because it wasn't there. It's not taught. It's not part of the curricula. So I do a lot of medical malpractice work. And the biggest problem is the gynecologist who does it for the first time. They get sued. I look at my lawsuits that I'm defending or giving an opinion on. Almost always, it's the gynecologist who gets sued in their first 10 cases because one, they're too aggressive. They're removing too much. They don't know the anatomy of the regions that retract. There's a region in the labia that retract dramatically, and what you think you're leaving labia is actually gone. And also, they don't know how to get rid of dog ears. That wasn't trained. You didn't learn that doing episiotomy repairs. They don't know how to reduce the clitoral hood area. They don't really know the anatomy of where the clitoral nerves are. And so the doctor who has zero training is the one I end up giving an opinion on medical legally and trying to defend. But it's really dangerous. The doctor with no training doing these, you look at their CV and where did you learn how to do cosmetic gynecology, and you can't find it. There's no courses for it. And the defense that I hear all the time is, well, I learned that in residency. We do a lot of deliveries of baby repaired torn labias. How many of that did you do in 4 years? One or two, right? And so it's hard to defend these doctors without formal training. So you must be trained. You got to go to the conferences. You got to go to a live hands-on training. If it's not me, go to the ones in Europe. Dr. Bader has one. He's a graduate of mine. In India, Dr. Sejal Ajmera. Egypt has a good program in Dubai. And so many of those around the world, there are a lot of places to train, not just in the US. But you've got to get trained before you actually try doing this, or you're going to get in trouble. You'll eventually get in trouble because that plaintiff lawyer will ask you specifically, show me your training and show me your case list. Okay. And for patients out there, and there'll be patients watching this, you know what? Go to the doctor's website, look at their CV, find out where they've trained, specifically ask them, where did you get your training? And then here's the biggest thing. If they have no pictures of these procedures or have only a handful, be very wary. They will tell you, oh, well, I don't take pictures because of patient confidentiality, blah, 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 blah. It's because they don't have enough cases. Bottom line is they don't have enough cases.
I couldn't agree more.
Yeah.
We have issues with patient confidentiality. Is a lot of patients don't want us to use their pictures, but at the same token, but I still have an album that's this big.
Right.
If everybody let me use their pictures, my album would be this big. So if you're a patient watching this and you come to myself or Dr. Alinsod, please let us use your pictures. We de-identify any markings and things like that. And they're perfectly confidential because patients want to see before and afters. And so I always really encourage our patients to do that. But sometimes not everybody wants to
Right.
use their pictures. Or like you said, they live out of town and then we don't see them back for the follow-up pictures. And then the follow-up pictures are just not as good a quality for me to put it in my album. So
That's true. One interesting fact I have is the longest span between my before and after pictures was a lady who lived internationally out of the area, and she came back for her post-op picture 10 years later.
all right, there you go.
But I got it.
Where can people find you, Dr. Alinsod?
Well, I just created my new website. I moved from Laguna Beach. I had my 18 years of practice in California and Laguna Beach. Before that, 10 years in LA. But I just moved to Dallas. And so I also have a secondary office in Las Vegas. So I'm in Dallas and Las Vegas. And you can easily find me at alinsodinstitute.com. So just alinsodinstitute.com is where all my new material is. We just launched it 2 weeks ago, so we're still building it. And for the doctors who want to learn how to do these surgeries and do an online teaching, you can very inexpensively join gyneflix.com. It's GYNFLIX. Gyneflix.com has my decades of all my very intricate and detailed videos, plus my 3D photos. It has all my regular photos too. And you can join my newsletter. I have two newsletters, one for the doctors. It's called Cosmetic Gynecology Newsletter. And for the lay public, I have one called Feminine Wellness Newsletter. And you can find all that on my website. You can just click on it and you can join it. So it's pretty easy, alinsodinstitute.com.
Yes. Thanks for joining us. This was so helpful. So if you enjoyed listening to this podcast, please like, subscribe, and it would really mean the world to me if you would take a little bit of extra time and give us a 5-star review.
That's fantastic. I'll do it myself. Thanks for the invitation. And for those who are watching, this is the best podcast out there.
Thanks for listening to Healthy Her. If you enjoyed today's episode, please leave us a quick 5-star review on your podcast platform. Your feedback means the world to us and helps others discover our show. Do you have questions or want to discuss a particular topic? You can reach us by emailing ask@dramybrenner.com or by calling 513-204-8403 and leaving a voicemail. We might feature your question or comment in an upcoming episode, so don't miss out on the chance to be a part of the conversation. And don't forget to subscribe so you don't miss any of our upcoming episodes. We appreciate your support and can't wait to have you back with us next time. Take care, and remember, your Healthy Her journey begins with you. This podcast is for general information only and does not constitute medical advice, the practice of medicine, nursing, or other healthcare services. No patient-physician relationship is formed. The information in the podcast and any references, material, or links are at the sole discretion of the listener and not meant to be a substitute for professional medical advice, diagnosis, or treatment. Listeners should not delay or disregard obtaining medical advice for any medical diagnosis or issues that they may have and should seek medical care or advice from their healthcare provider for any such conditions.